Amy, thanks for that note. Glad you can hear and see, but struggling with your headphones. You might be able to type if you've got any questions, so that might be helpful as well. Okay. Good afternoon, everybody. I will repeat the message that I've just said again. We are being recorded. We'll be speaking today about social prescribing. Good afternoon, Dean. I'm just doing an introduction and then we'll pass over you for your couple of minutes introduction to the session and social prescribing. So we are recording the session. Please place your questions in the chat box and please turn your microphones off and also your cameras off. This is a very quick webinar, so we're going to be giving you lots of information and updates about social prescribing. It's part of a series. Tim and I will be sharing some slides with you about information and then also more about the PCN advice offer. We will be doing a quick Menti at the end of the session just to ask about future webinar content that's suitable for you. So cameras off, mute yourselves, that would be fabulous. Excellent. Okay, so we have half an hour. I'd like to introduce Dean, Dr. Dean Dorset, who's from Ipswich and East Suffolk CCG. And Dean's just going to spend a couple of minutes just saying why social prescribing and the personalised care roles are so important in primary care, and just give us a bit of a context to taking this forward with the session. Thank you, Dean.
Hello, everybody. Dean, welcome everybody to the start of changing the world, basically. So I'm Dean. I'm a clinical lead for personalized care and social prescribing, and I do quite a bit of work on health inequalities. I just wanted to frame this short introduction because most of the work is going to be done by yourselves. And I wanted to frame it in 3 facts, 3 questions, 2 quotes, and 1 very big challenge. So the 3 facts. We probably all know that personalized care started with the survivor and user movement in the 1970s around disability and mental health, where people took direct action and lobbied so that they could be in charge of their own well-being. The second fact. When I qualified as a GP many years ago, we had 11 GPs, 15,000 patients. Now we only have 6, and we have a massive team of social prescribers, physios, paramedics, nurse practitioners, health and well-being coaches. And on top of that, management challenge, we have 2,000 more patients. We have higher demand, higher bureaucracy, and higher standards. The last fact. Across the health service, there are 5,000 to 6,000 less GPs, and every part of social and healthcare is challenged and beyond capacity. That was before the financial and social shocks to our system that COVID brought and the levels of inequalities that it laid bare. So those are the 3 very sobering facts. So in this context, the 3 questions are, how do we implement personalized care and patient needs? How do we use the 6 pillars of personalized care to fix this, well, essentially massive mess? And how do we integrate all our systems? And I'll probably end with 2 of my favorite quotes and then the 1 big challenge. The first one is from Laura Gilpin, and it says, it's too bad patient-centered care is not rocket science, because if it was, we would be very good at it. What we are doing is quite simple. It's just putting the humanity back into health and social care. And we probably need to keep that in mind, that in actual fact, what we are trying to do is that we are trying to treat patients, treat citizens, treat people like family. And then the last and my favorite quote comes from the founder of modern medicine, Hippocrates. And he says, wherever the art of medicine is loved, there is also a love of humanity. And that is the absolute critical key in making our care, both in the social sphere, in the health sphere, and in the voluntary sector, more human. We make it better. we make it easier for ourselves. It makes financial sense, and more importantly, it makes moral sense. So we will be going through lots of complicated strategies from NHS England and from our leaders on high. But what we need to remember is the simple fact that we are just trying to make what we do more human. Thanks.
That's wonderful, Dean. Thank you so much for that introduction. Some really, really key and important messages there, and certainly sets the scenes for what Tim and I are going to be going through now. So thank you for that. I'm now going to share some slides with you and work forward with the session. Okay. So who are we? Tim and I are regional facilitators offering some PCN advice to you all. You will have received, and we can send on again, our bio. So I'm not going to spend much time on this, but we've been working in social prescribing now, each of us, for at least 5 years. We're core members of the National Social Prescribing Steering Group. We also work on social prescribing external to our roles with the regional team. We are not employees of NHS England, we are associates. So this offer really is not about performance management. It's just about a bag of carrots, about us sharing our expertise, our knowledge, our skills and experience of personalised care, the 3 roles and social prescribing with you all to help you make the best effect and the best use of the resource that's available. So as little as 10% of a population's health and wellbeing is actually linked to access to healthcare, so access to primary care services, secondary care services. The rest of it, as you can see here, is all the things around us that make a difference. And this really, in terms of social prescribing, is where those link workers can focus on those social determinants of health, which we know and are evidenced have a huge impact on somebody's health and well-being, and also happiness in life. We can see here as well that the lack of access to these elements within a person's life can also exacerbate their experience of health inequalities. And we know that primary care networks are going to have a role in addressing your local neighbourhood health inequalities. Your link worker, your health and wellbeing coach and your care coordinator can all play a really important role in supporting you in achieving this for the people that you serve in your local communities. Now, this may be familiar to some of you from the GP Forward view, which is quite old now, but all those years ago, it highlighted social prescribing as one of the key areas to make an impact for primary care. Actually, if you do social prescribing well, it's well planned, it's an approach, it's not seen as just a role within primary care. You have an impact on supporting self-care, increasing personal productivity, not just of the link worker, but of a number of roles within your practice. The work flows much more productively. You increase your partnership working, particularly into the community where these health inequalities will be showing where they're being experienced. Developing the team by working in that biopsychosocial model of health, not just our medical model, which is the sticking plaster for our patients, and also active signposting. You'll see here that the NHS model really does focus on the link worker, but social prescribing is not the link model alone. It is about all these things being in place. The PCN advice support that Tim and I will be offering PCNs in the region is to explore whether and how all of these elements can come into play within your practices and your PCN to support your link worker, to support your staff, to really make the most of social prescribing. Social prescribing is everybody's business, and it forms part of our thinking around how we work in communities, how we address health inequalities, and how we work in a population health way. It's asset-based and strength-based. This doesn't come with any easy to do manual. So Tim and I and the regional team really want to support you to understand what this different model of health is and how you can embed it safely and with a high quality within your practices. So there's some fundamentals about social prescribing before I pass on to Tim. It's about the what matters to you, transformative conversations. This takes time, building trust and rapport. It very much fits into that triangle of personalised care of NHS England, and it differs from person to person. And this is a challenge for all of us. 6 to 12 sessions up to an hour each long. It may differ from person to person. That flexibility is key. Link workers use health coaching approaches, and they develop a plan with the patient around goals and behaviour change. Supervision is absolutely key. It's also mandated in the DES. And this is because our link workers are seeing the most vulnerable people in our communities. Around 6 to 12 sessions modelling, one might see a link worker for one session, one might see them for more. It depends on the needs of the person. An annual caseload in the guidance of around 250 is safe for a one person full-time link worker. Again, this is in the DES guidance. Home visits where appropriate, and it's not our traditional primary care consulting approach. So we need to develop that virtual team around the link worker to build a local social prescribing model. And Tim and I are supporting you to do this within this offer. Community capacity building, a key, is not just about caseload management and seeing individuals. How do we build capacity for the community to look after themselves? And the link worker and the coach can play a key role in doing this. And we must capture outcomes. At the moment, we're looking at SNOMED and OS4, but we can certainly have conversations about what else is out there, including case studies and other measurements. So I'd like to now pass over to Tim.
Thanks, Sian, and thanks, Dean, for a brilliant introduction. So I'm going to build a bit on what Dean was saying about the mess we're all in, but some really positive stuff's been happening. So before COVID, back in May 2019, was round about when the first PCN link workers started being appointed under ARRS. We know there are about 1,500 in England now, which is an amazing change. Most PCNs have at least one. And that's already started to change the nature of the relationship, primary care to its community. And I think in particular, the RCGP picked up during COVID just how much impact those link workers were having. As Sian said, about 250 cases per annum was what was originally suggested as a likely maximum for a full-time social prescribing link worker. And the emphasis in the original guidance is absolutely on time, having the time to work with people who have often been around their houses, bounced around services, never found they fitted anywhere. And that's the absolutely transformative bit of social prescribing, spending the time to get to know what really makes someone tick. And again, as Sian's mentioned, that need to network with the voluntary community faith and social enterprise sector in your locality. Social prescribing isn't a standalone process. There's not a lot of point in having lots of travel agents if there aren't any holidays, or the travel agents don't know about the holidays. It's really important that we build those connections, because sometimes all the person with at risk of depression needs is someone to go fishing with. They may not need hugely complicated interventions, but that can change their lives. And I think the original set of guidance not particularly strong on the whole idea of proactively reaching out and case finding. That wasn't part of the original design, but I think things changed quite quickly. Next slide, please, Sian. So I think probably most of us don't really want to try and remember what the original first lockdown was like and the chaos that hit us all. But I think we've seen amazing flexibility, obviously, from primary care, but also and very much particularly from link workers, who a lot of whom were being recruited and inducted actually in the middle of the crisis. And some of that flexibility has been great, imaginative. Some of it's been less so. We know that some link workers in the region didn't even have phones, laptops or remote access at the beginning. So there were some really stressful times for some people as we got all that sorted out. Obviously, during the lockdowns, there was particularly focused work reaching out to people, doing very short interventions, checking they were getting food and medicine, all those sorts of things. And again, great flexibility and imagination shown in a lot of places about how best to make sure people were safe and well. And I think that links to this idea of getting back to basics and getting back to what we started off trying to do. I think everybody accepts that COVID has been really complicated. and as things get easier, we should be able to go back to focusing more on the real focus of those link workers. And as I said earlier, RCGP can see the power of link workers in terms of the health inequalities and so on. Also, we've seen in the region a huge surge in the number of care coordinators, but we're not entirely convinced that all of that is exactly as perhaps it was originally designed, but during the crisis that's very understandable. But obviously part of what we'll be looking to do is to focus that in the most appropriate way going forwards. We haven't seen as much recruitment of health and wellbeing coaches as we might have expected, and that is in one sense quite interesting. I think it's also possibly a reflection of the fact that we need to address some of these social issues before we get on to some of the clinical ones, so that may be quite logical. So then thinking about, okay, if we are coming out of COVID, what difference that's making and where we find ourselves. Obviously, across the systems, both statutory and voluntary, there's been a huge demand, lots of very stressed workforce, and that also a great deal of satisfaction in having helped people cope with some really difficult times. But we need to acknowledge that staff must feel valued and supported. And there is some risk with some link workers. I think we've seen quite a lot of turnover in certain places where that doesn't feel like it's the case. There's a really important point about the IIF targets, because we do need a mature approach to that. Although it hasn't been made explicit, there is an assumption that to get those targets, you do need more than one link worker, depending on the size of your list. And that original guidance about 250 referrals a year or thereabouts has not been replaced by that IIF target. And again, I think we need to all be looking at what we're trying to achieve with our link workers, because it's not just about referrals, in particular in terms of tackling health inequalities locally. That new responsibility will be looking at proactive work by link workers reaching out rather than waiting for referrals, because there'll be particular groups that we know are facing particular challenges. There will be the need to build networks with certain communities, and hopefully there'll be a chance to engage with other bits of the system in population health management and other pilots. So we do need to make sure that we're clear what we think the link worker is doing, or the team of link workers is doing, and how they're doing it, and making sure expectations are reasonable, doable and well supported. And then, as we've already mentioned, the issue about how the social prescribing link worker role fit with health and wellbeing coaches and care coordinators. Next slide, please. So I think the reason we called this Back to Basics is that we absolutely want to help you all to focus back on what matters most, and that's the quality of this work, which can turn the long-term unemployed, depressed, overweight, pre-diabetic resident into someone who is actively engaged in their community, not needing medication and so on. But that takes time. And if we don't have that time, then we're going to risk missing out on that opportunity to transform that patient's life. The DES requires a joint plan, and I think that there's lots of value in doing that as long as you've got the right partners around the table, and we can help you think that through as well. There's a growing number of children and young people social prescribing link workers in the region. We're starting from quite a low base, but it's something that nationally is getting a lot of attention. There's a lot of discussion around, so we'll be keen on sharing good practice around that. And similarly, there are some mental health link workers. Obviously, there are new mental health primary care roles coming. There are a range of places in Hertfordshire. We've got some link workers just working with Afghans at the moment, because of resettlement going on locally, and there are lots of ways that this role can be used, but we need again to think all this through. And then lastly, we particularly want to demonstrate that social prescribing is an absolutely key tool in addressing health inequalities and making sure the population's health is improved. But to really get the value of that, we can't just have single link workers in single PCNs not connected to the rest of the world. They need to be plugged in, and communities need to be joined up, and commissioners need to be joined up, and that's one of the exciting things about the new ICSs that we'll all be working together on going forwards. Sean, I think the next slide you wanted to talk to.
Absolutely, yeah. So today we have focused on particularly the fundamentals and COVID around social prescribing. But the whole of this series is going to be looking at the 3 roles, how they can potentially work together. And you can see this slide here. There is some further information that we can share at a future webinar if helpful. And we also propose that potentially there's a session on the health and wellbeing coach and also a session on the care coordinator. The region does have in post 2 mentors, one for each of those roles, and they are now where we were probably about 3 years ago in looking at numbers of these particular roles. And so there is a regional peer support session for each of those roles offered by the mentors. They work 1 day a week each, so not a huge amount of capacity, but they will certainly point in the direction of the information that's available, such as the Personalised Care Institute, and other sources of support. So Tim and I obviously have limited availability between now and the end of March. I would suggest if you are seeking to have a session with us to explore what it is that we can help you with, that you contact us. We've split the region across the 3 of us, across three ICS systems each. So you can see there our email addresses. Do take a note of them. The slides will be shared with you after today as well. And the email addresses should have been in the original offer that was circulated to PCNs. We are also supporting our integrated care system lead, so we're trying to connect this to make sure that all of that support is joined up with your integrated care systems as well. NHS nationally are looking at some point in the future developing some coffee break videos, but we were really keen to get some information out to you sooner within the east of England. So I'm going to stop sharing my slides now. What we propose to do, Tim and I have just developed a very brief Mentimeter, which I think Maxine has posted in the chat box. Please, let's see if we can add that again. Any questions that you've got? Yeah, it's in the chat box. If you click on Menti, we just want to see what your thoughts are on the types of webinar themes that you have, and we've given 6. If you've got any that aren't on the list, jot them into the chat box, please. And if you go to menti.com or click on that link, it will take you straight in to the presentation. I'm now going to see if I can present that. Okay, and come back out and share what people are saying. So just click on the link and it will take you. Hopefully you can all see that. Okay, so for the numbers on the list, we have 2 people that have responded. So you're going to be ranking these as to your priorities. And this will help give Tim and I an idea of what it is that we need to be focusing on in terms of the future webinars. Depending on our capacity, obviously we've scheduled 1 a month, but actually it might be that we can squeeze in an extra one, try and get some extra capacity to do more, bring in additional speakers. So we'll keep that going. If there are things that are not on this list that you would like us to present on, please type it in the chat box. We will be responding to the questions that come into the chat box and also to any suggestions that you have. Tim and I's role when we speak to you, we'll probably start off with quite an informal chat to find out what matters to you as a PCN and as a manager and as a clinical director or a team, as a practice, as a PCN. And then we can go from there as to what help it is that we can support you with in terms of your issues, your ideas. This is about quality improvement. It's about giving you the right information, the right background and support to take forward the best social prescribing that you can have within your area. Okay, so we've had 20 responses there. Please do keep carrying on with that. What we'll now do is go on to the next question. So I'm just going to change my slide. The next question is more about the practical elements of this, and it will be more about the timing of these sessions. So if you go on to the next slide, the next question, we obviously don't work directly in primary care. We know you're very pressured in your time and your capacity. We are recording these, so they will be available afterwards. We'll share the link as to where they're posted. We just want to know when's good for you. Again, if none of those answers fit you and there's something different, then please do put it in the chat box. This has to work for you. It's your offer. Okay. That seems to be working really well as terms of the timing that we've got right. So our social prescribing and personalised care leads gave us the right answer, which I had no doubt that they would do. Okay, so I think there's lots in the chat box for Tim and I to catch up on. Tim, do you have any comments to add to what we've done so far?
No, I just think I think there's some something developing in Norfolk and Waveney, which is good. And I don't think there are any questions other than what green and blue social prescribing is that we haven't touched on. Are there?
Okay, do you want to say what green and blue is then?
Yes, so I've answered it in the chat, but yes.
Excellent.
So green social prescribing is helping people access a natural environment for their well-being, and blue just is another bit of jargon for where it involves water of any kind. But cold water swimming, of course, is a particularly good example of blue. And actually, we heard, didn't we, Sian, an example recently of where a PCN actually had a welfare fund which allowed somebody from a deprived group to get a second-hand wetsuit so they could join a cold water swimming club. So, you know, simple things like that can really make a difference to people being able to take control of their well-being.
Absolutely, and there's things like personal health budgets as well that we might like to explore, and how link workers, maybe health coaching, can link into that. So that's another opportunity we can dig into if that's useful. Let us know. The east of England, unfortunately, very sadly, was one of the only areas in the country that didn't get funding for green social prescribing as a pilot. So we are very keen to link with you that have green spaces and blue spaces that you're utilising with social prescribing. We have a regional lead from the National Academy of Social Prescribing and the Thriving Communities programme, which we'll also be able to talk to you more about, that is very keen to get those spaces connected across the region and us to know the good work that's already going on. I'm sure it's not from a zero base as well.
And I'm delighted to see that Dean's very keen to share the recording, and obviously we want people to have access both to this very enjoyable half an hour, but more importantly perhaps to Sian and I if they need particular support with any particular areas. As Sian mentioned, because of our time limits, what we may do is if there are 20 PCNs that want to talk about green social prescribing, then we probably try and get you together in some format like this. But otherwise, clearly we'll also be running these webinars on a monthly basis till March 2. Any closing remark, Dean?
Yes, just quickly, I think you guys have covered it all. I think it's just about injecting some urgency into it all. I think the question is not whether we should do it, it's whether we can afford not to do it. And in a lot of ways, although the last 2 years has exposed a lot of stress in our national system, the aftershocks in terms of the social and financial shocks of things like sort of Brexit and the pandemic and all the rest of it is going to need personalization and social and social prescribing more than ever. So it's something that it's not about building back better, it's just building back. Yeah, so in a lot of ways, we are maturing, we are evolving, and the link worker will go from a simple link function to essentially a coordination of all the roles that are coming out, and integrating the social health system, the voluntary sector. So big job that needed to be done yesterday.
Perfect timing, Dean. We've just hit the 2 o'clock mark. So thank you so much for your contribution today. Thank you everyone for attending. Thank you, Max, for organising it and keeping us to task. Thank you. And the recording and slides will be available. We will circulate that on and also let you know of the next session as well. Thank you, everyone.
Okay. Bye, everybody.
Thanks. Cheers. Has the recording stopped, Max? Stay on for a sec.
Hold on, sorry. My system seems to have gone slow. I'm almost about to finish. Oh, crikey.